the Hong Kong team did the Hong Kong team did for with because Hong Kong team from Prince of Wales Hospital, the Chinese university team, they are both surgeons and endoscopists. They have a study that the cost effectiveness is EFTR is better than the laparoscopic, yeah, because they are the surgeons. They compare their own patients. And also, you can do a gastric stir. Sometimes we don't perform stir in the stomach because the the anatomy side, the curves on the lesser curve or in the fundus is very hard to perform a stir. But sometimes, if you are not so confident to do EFTR, in some locations like body, lesser curve, antrum, you can try stir as a beginner. I mean, you feel like safer in this area that you close it, you just close them closer. You're not caring about full thickness defect. It will be okay. And also stir in the rectum is doable. Stir in the rectum is doable. Okay. This is stir for stir ET. So I quickly go through the technical parts of the stir, and my last slide is about tunnel infection. So we talk about all the fancy things that all the techniques can bring, but if you say it's a 100% successful technique, if someone say my technique is 100% safe, 100% successful, I would say you're just doing not enough cases to encounter such complications. So I will start with a case discussion, and I will show you unpublished data from our group. So background, we already talked about this, and this is a male patient for a 57-year-old, and dysphagia over the past 20 years, and he's very difficult for swallowing. He's on NG nasoenteric tube placement for nutritional support for 2 months. So it's a very severe case in case of chalacia patient. And the past, he did the Botox injection 20 years ago, maybe relieve a little bit, and then the symptom recurred. And also has a nephrectomy for the left renal malignancy last year. So this is a examinations. You can see very there's a large food residue in the esophagus, on the barren swallow. You see the mega enlargement of the esophagus and its esophageal type, sigmoid type, and it's really the barren hardly pass into the stomach. But then he's referred for a POM for surgical for POM for treatment. Actually, from the procedural record, it's not that complicated, but you see it's beautifully done. This is a pre-myotomy GEG-GJ. We had a successful elevation by hybrid knife, and we made a beautiful tunnel. You see, these are the muscle layer, and it's not like fibrotic, and it's not. Of course, I expected it to be a very difficult one. But just from the procedure, it's not done by me. I don't know who performed this, but I think it's a beautifully done POM procedure from the record. But you can see the thickening of the muscle it's very severe. And afterwards, it's a beautiful closure, and the opening of the GJ looks fine. But then post-operative day 1. There's a fever to 39.3 Celsius, and the neutrophils percentage is about 91%. And we can see the significantly dilated and fluid accumulation in the esophagus. You see bilateral pleural infusion. Then we put him on antibiotics. But on day 3, the patient is not recovered from the antibiotics, or the inflammation with the PTC, CRP is going steadily high. Then this is a sign for second local endoscopy, by the way, because if you put them on antibiotics and it's not resolved, then you are thinking about there must be something wrong inside. So then we immediately go inside to see. There's a lot of fluid retention. The tunnel is swollen. You can see the pus coming out from the hole there. So then the first decision is you need to remove all the clips, because the clips keeps the pus into the tunnel. Then we need to drain the pus out. The first thing, the principle of surgical treatment of this kind of infection is drainage. So we pull out all the clips, but it's not enough, because the whole tunnel will retain everything into it. So we cut the mucosa all the way down to the end.
Isn't the tunnel being drained into the pleura because it has a huge, it's already being drained, or not? When you say, you can say that or not?
Yeah, if you have a pleural effusion at the same time, we do the drainage at the same time. So yeah, from outside. Yeah, the ultrasound guided drainage. So if
you put the chest tube,
not chest tube, it's arrow, the small one, the small tube is ultrasound guided drainage. It's arrow tube. It's not that big. It's not like surgical drainage with the thick tube. It's just small tube for continuous drainage. So if on the CT scan pleural effusion, then you just do the drainage right away, because if there's nothing in the pleural effusion, even it's a very clean pleural effusion, it can cause fever. So if you see some pleural effusion, just do the drainage. If your interventional ultrasound guy said, I can do this, just do it. So the first thing is endoscopic look, and you do the drainage on both sides. One is here, one is in the tunnel. So we cut through all the mucosa and clean it thoroughly with your saline, and then put the nutritional tube into the small bowel, because you want the patient on nutritional support to heal the defect, because you need to let the granular tissue to fill out all the defect in the tunnel so that it can heal. That's the principle outside. That first you do the drainage and give the antibiotics and also the nutrition support for the patient to heal for this defect. So then the post-operative status of we cut the mucosectomy, then it will go down slowly, and we remove the nutritional tube and put them on liquid diet. Then it's on eventful. So there's a trick inside, because we are not afraid if you feel that your tunnel is not going to like deep places, because sometimes if you see the tunnel infection and it's already granular tissue going up to fill the defect in the tunnel, you are not afraid that you give patient drink. Like if you drink sterile water, it's just the natural irrigation for the tunnel. It's a small trick inside. So otherwise you need another tube to do the irrigation every day. Actually drinking water helps you for the natural irrigation of the tunnel, because you drink from here and then actually you are washing all this pus into a natural drainage into the lumen. This is from us. This is a discussion part, which is on unpublished data from our group, that we look into 14 years of our data. We retrospectively to analyze all these patients receive achalasia for POEM and for stir. We found 17 cases of the tunnel infection. 10 is men, 7 is female. And among them is like 9 cases with POEM, 8 with stir. So the incidence rate for POEM is about 0.2. Incidence rate, the tunnel infection rate is 0.3. 36. It's not that high, but you need to know how to deal with it just in case you will encounter one day. Nothing is 100% successful. Until you reach the number, you will see complications. So usually we need to insert a gastric tube into the tunnel, sometimes for the drainage. If in this case we feel that it's impossible for the natural the drainage for the tube, then we just do the mucosectomy to open the tunnel thoroughly, then have a good drainage.
We give preoperative, systematic preoperative prophylaxis.
Yes. But now in China, the antibiotic use is very strict. So if it's not complicated cases, like just naive patient, type 2, and the procedure time is not that long, we won't administrate any antibiotics afterwards. We can only administrate when the WBC is higher. Prophylactically, we will give 1 dose in the procedure. But afterwards, we need to check the blood test and then decide whether to give or not. It's a 2nd generation Cepro. Sorry? Yes, I was talking about this.
The gastric tube is inside the tunnel?
Yes, if in the tunnel is not that too much pus inside, you can just insert the gastric tube inside. You need to wash it first, and then clean it first, and then put the NG tube.
Right tube?
Hmm?
Right tube?
NG tube, yeah, NG tube to put in the tunnel.
And the patient in oral fluids only?
Hmm?
The patient feeding is stopped or in oral fluids?
No, if you put the NG tube into the tunnel, it's the first tube. Another tube you go to the small bowel to give you nutritional support.
Nasogenital or just
Gastrojejuno. Yeah.
Nasogenital.
Yeah.
This give prophylactic antibiotic in such case, is it guidelines or this is all institutional consensus?
In the Chinese guideline, they support to give prophylactic, but if it's a treatment, then because our pharmacists are very strict on a bit to the guidelines. So the guideline now we have a Chinese guideline to support the use of prophylactic antibiotics. So risk factors of tunnel infection we still not that clear because the case number is not that high to have a conclusion, have a variable study, but possibly including lung disease diffusion, sigmoid esophagus, and significant food retention because you already the food retention residue is very always there, and all this bacteria is being there for many for a long time. Maybe there's a shifting of the bacteria into the tunnel, even if you are cleaning it. So it might be these are our empirical I would say experience from our post for this study. And also management, antibiotic use, CT, endoscopy, incision drainage, and also drinking water is allowed to facilitate the natural irrigation, I already said, and also the nutritional support is very important. There's some preventive measures. This is not only from our group's experience, but from literature. We just collected here for the discussion. So maybe fast longer, and repeated gargling with still water before surgery, and intensive irritation of the esophagus and stomach with still water under endoscopy, and the restricted sterilization of the scope during surgery, during the POM procedure. I don't know how you sterilize the scope, but now for our center, if it's a tunnel technique, and also if it's a nose technique, we need to strictly sterilize it, the scope. It's different from different from the daily practice. And prophylactic.
Practically, you are going into the oral cavity. I understand. Once you put it in the oral cavity, it's not sterile, so you're still going to give germs to it. It beats the purpose. So even if you sterilize it, so you're going to put it in the mouth is full of germs, so it's.
Yes, but
to sleep
just
better,
minimize the risk.
to sleep
Yeah.
better.
Just principally minimize the risk. So and place the gastric tube for monitoring drainage. So in the event of persistent fever, chest pain, and elevation of blood count in cell count in blood, and 2 days after POM, a chest CT scan and second look endoscopy is indicated, which we talked about this yesterday. So I finished my talk with these 3 talks, talking about stir technique, EFTR for GIST, and also share a case of tunnel infection. You might be worried in the future when you reach a certain number of cases, you might encounter one day in your practice. So just equip yourself with all the knowledges, and then that's all for my today's sharing. Yes.
What about dealing with the mucosa necrosis? Yesterday you said unless the mucosa is intact, there's no perforation in bone. What if it becomes ischemic? Is it more frequent than the infection? What is the percentage? You go to 0.2% of the tunnel infection.
Mm-hmm.
What is the prevalence of necrosis of the mucosa after bone and through perforation? Which is more frequent?
Necrosis won't be that, I would say, won't be that easy if you stick to the technical point, because one thing is never touch this side too much. If I tunnel, I will make the tunnel very close to the MP layer. It's not the, in the esophageal ESD. Maybe my submucosal layer, I will still leave some submucosal tissue above the MP layer, because you want them to keep intact. Sometimes you hit your scope cap will scratch it open for the muscle bundles for the esophageal ESD after esophageal ESD, but for the POM, because I want to protect the mucosa, so I'm going very deep, just above the MP layer, I will create a tunnel. So you will see my tunnel very clear. You will see all the whitish tissue of MP layer. And also, it's good for you to have the orientation, because when you are in a tunnel, you need the muscle fibers to guide you. Where is the vertical, where's your correct direction to the GJ? Because if you see the muscle bundles very clearly, you just go vertical with the muscle bundles and you don't go outside to see. You don't need to go outside and see. So one way is to stick to the MP layer when tunneling. And if you want to coagulate on this side, never coagulate directly if there's bleeding. I always inject first. Always inject first to create more cushion there, and I do precise hemostasis. Don't sometimes that when they're bleeding, then some beginners will panic and then they just grab something and boom. Don't do that on the mucosa side. You should be very precise on the hemostasis on the mucosa side. So usually I will inject and have a temporal tamponade on this bleeding vessel so that I can see the spot of bleeding spot. And then I put my knife there, do the hemostasis, but done. It's a precise hemostasis on that side. And if it's a massive bleeding and you have to use crack grasper and have to have a prolonged hemostasis there, you go outside and check afterwards. If there's whitish, then you close it. These are all the tips that prevents you from the high risk, the risk of necrosis. So if you stick to those rules, It will be very easy to avoid necrosis.
And if it happens, how do you manage it? If it happens, despite all these measures, so you only put the
Just
10
leave it. Just leave it.
You just leave
Yeah,
it.
put
And
it on
antibiotics
nutritional
and you leave
support. Put it on nutritional support, and then the tunnel will close, and then the other side, the empty side with the granular tissue, they will getting closer to the mucosa, and it's healed. Yeah, it's just like dealing with mucosa opening. Yes.
Tunnel infection. I should open all the tunnel, or can I open part of the tunnel and put a pigtail inside the tunnel?
Put the pigtail. Pigtail drainage, just because pigtail is usually not that effect, because it's too small. The diameter is too small. Even if you put a 10 French, it's very small compared to drainage tube of the gastric tube. Gastric tube is sometimes 5 millimeters. You need to have this drainage very quickly. I won't say pigtail. We never tried pigtail. But to my understanding, because in the esophagus, it's natural gravity drainage. It's not like pigtail. I'm thinking about like how you put the pigtail, and what the position of the pigtail, and it's very hard to expect that how they come out with the gravity, because it's up and down. So you just put it there with the other, you suck it out, or you let them drain down in the stomach. So it's natural gravity drainage.
According to physics, we should be stuck to physics rule. Physics, there is a rule of capillarity, which means that fluids come from down upward in capillaries. So I think the idea of pigtail is a good idea. The second, why you are in a hurry if the fever persists for 3 days to go on and open the tunnel, why we shouldn't give broad spectrum antibiotic cultures and wait? And because yesterday you said that you give Coca-Cola for 24 hours to remove all food debris, and even if we found any food residue inside the stomach or esophagus, we should remove it before we start. So we didn't expect that inside the stomach is food residue. So if it's turned to vaginal abscess or something like that, why you didn't use endoscopic ultrasound to make the image by pigtail and something? Yeah, this is an idea. Yeah. We have no experience in such technique. Why not? If it sounds wise, why not?
I haven't tried, so I cannot give like a. Be frankly, we don't have this experience with pigtail, but yes, but my feeling is the drainage. Well, the diameter of the drainage is not that enough because the person is very sick.
The stability of the gastric tube, how can I make the gastric tube stable inside the tunnel after I open it?
Yes. If you open it, you just open it. Don't leave it. Don't leave it in a tunnel. If you open it, just put it in the NG tube and then nutritional tube, and then it's done. So if you open it, you still have some tunnel. You can put the drainage in. Yeah.
Is it easy to take out the clips from the entry of the tunnel? How do you take down the clips from the entry of the tunnel? Is it easy?
Yeah. Just use a. No. You just use the forceps. You just use the foreign body forceps. You don't have to retrieve it from the mouth. You just throw it in the stomach. Yeah. Yeah. Sorry, after? Yeah.
What's your care measures for the patient? For how many days you keep him? For how long can he go? What PPI? You give PPI?
For uneventful form, we will discharge the patient on post day 2. So observe for 1 day, and if nothing, like no fever, no pain, yes, it will be pain, but it will be pain. But it's not like extremely painful. Sometimes extremely painful means that there might be something wrong, like bleeding in the tunnel. I haven't talked about bleeding in the tunnel, but bleeding in the tunnel is also a complication, but it's much rare than the infection in the tunnel. So if it's not extremely painful on day 1, no fever, and the patient drinks fine, and we can discharge them. Usually just 1 day observation.
It's like the same for thickness.
For thickness depends on how large is lesion, how confident of your closure. Usually 2 days, 2 days in hospital, and then on clear fluid and go outside.
And you give PPI.
Yes, for thickness we will give 1 month PPI. Yes.
Do you do contrast study after the point to be sure of your closure? No?
Yeah, in early days, there's a group that actually does a contrast study, and they found that they found that some clinically, I would say, they found some leakage, but it's not clinically evident. So they stopped doing this. It's maybe 10 years ago, 11 years ago, some group does this. They do everyone on contrast study, but they do see some leakage between the clips, and then it gives you a dilemma. Is there a real leakage? If the patient don't have any clinical manifestation, then it's not meaningful. So they stopped doing this. So it's an early days story. I know it because I know the group that they do contrast study, and they tell me that you can find a lot clinically no symptom leakage, but it doesn't matter. So, and if you say leakage, then gives you a clinical dilemma whether you treat it or not, whether you have a second look or not. So patient manifestation is the most important thing to look after afterwards, I would say. If they're feeling good, why we should look at that?
What is your size limitation for the FTI? So that for sure is 2 to 3 the ideal. There is size limitation for the FTI, or is it the same?
We try to make a guideline in Asia Pacific area, and all the experts argue about this size limitation. And finally, we agreed that 3.5 will be, for most of the people, is acceptable. But for experts, they will say, I mean, for GIST, because 5 centimeters, usually you have high risk. And also, the GIST, the priority is you retrieve the specimen en bloc. If it's too large, you cannot retrieve it en bloc. Even if you resect it en bloc, then it's not meaningful. And it's full thickness, you retrieve this piecemeal, then you must have something left in the lumen or even outside. So then we agreed on that consensus. It's not published yet, but it's led by the MBIG group. We discussed for the past 2 years. I think Professor Zhou also say 5 centimeter, but but Indian doctors persisted maybe 4 centimeter. But finally, I think the panel cut down to the upper limit of 3.5 for most of the cases, because it's a guideline that maybe Asia Pacific area or other doctors will see it's a guideline. So you are guiding most of the people how you do this. So we stop at 3.5. It answers your question, but it's no, I would say, yeah, we still do large GIST, but never exceeds 5 centimeter. Last APDW, some group also report on larger than 5 centimeters. But I think the risk of you getting high risk GIST is very high. So the ultimate goal is not resected, it's the patient's overall survival. So I would say technically feasible doesn't mean oncologically feasible. I would say that. Okay, I think I answer most of the questions and hope you are satisfied. And I don't know whether I keep it basic or not, because I don't know. So show any questions
So
when we have.
starting from
Yeah.
basics to advanced.
Yeah. So we can still have discussion time when we have hands-on. Okay.
Thank you, Tsai, for your excellent, detailed lecture. about everything regarding subepithelial lesion, starting from stair up to full thickness resection. And now, according to audience requests, that Dr. Hani told me that most of you asked yesterday for a lecture about lesion characterization. So Dr. Hani will start his lecture now about lesion characterization. We have 20 minutes, Hani. After that, Dr. Karim Assam will take the lead for the complication, and then we'll spend the rest of time at OR on sedated live animal.
صباح الخير. ان شاء الله اليوم الثاني يبقى احسن كمان من اليوم الاولاني. وبناء على طلب الجماهير بقى الليجن كاركترايزيشن. How to describe the lesion. Why should I describe the lesion? There are wide spectrum of lesions with no rigid rules. Needs a lot of experience. So we must all talk a common language. When I see a report from a colleague, I am able to take a decision based on this report. So I can take full data and decide whether this lesion is eligible for endoscopic resection or not. So what do we need to describe a lesion? We need equipment. You must have a high definition scope. You don't use the old scopes anymore. You must see clearly to describe the surface pattern, the visit pattern. You must have a high definition scope with chromoendoscopy. You must have a clean field. You must clean your field thoroughly before starting to describe your lesion. You will start dissecting, removing your lesion. From this, you can reach a data and put a plan accordingly. So let's see how important is this about the field cleanliness. Can you see this picture here? This is a gastroscope with secretions of froth in the stomach. Sometimes we see this, it's okay. There is nothing here apparent. You can see this photo after we clean the field. this is an early gastric cancer. You see how easily you can miss such a lesion without cleaning properly your field. So make sure you properly clean and expand your field. You can see even small lesion hidden under secretions of froth. You can see here, this is another gastroscope with minimal air insufflation. Sometimes just we go in and out without insufflating well. You see after air insufflation, this is an early gastric cancer. You can see how serious this can go without properly examining your field. Those are different pictures from colonoscopies before cleaning and after cleaning. You can see how easily you can miss such lesions. So this is very important. Clean your field thoroughly and examine every detail. So it's about mapping the lesion, putting a map for the lesion. You must describe the site. By the way, this description is very important. We had this patient who undergone a wrong surgery based on a wrong description of a colonoscopy. She did a right hemicolectomy and the lesion wasn't even there. In the end, we removed it by ESD. She didn't even need to do this surgery. Then we describe the size of the lesion, and accordingly we describe what endoscopic resection technique we can use. The morphology of the lesion, the most important, the gross picture of the lesion, its surface pattern, its vessel pattern. From those data you can expect the pathology of the lesion, whether it's benign or malignant, and you can decide the depth of invasion, or predict at least the depth of invasion. You can choose for 100% of course, but at least you can expect the pathology of the lesion and decide whether it is eligible for endoscopic resection or not. Let's revise our layers of the GI tract and see where are the limits of our endoscopic resection. So we have the mucosa composing of the epithelium, the lamina propria, and the muscularis mucosa. This is the mucosa. Then we have the submucosa. This is called T1A, T1B. The muscularis propria is the T2. The adventitial or the serosa is the T3, and outside the wall is the T4. So our limit of endoscopic resection is the first 1/3 of the submucosa. That's called SM1. Why this level in particular? Do you have any idea? Lymph nodes, that's right. When you go deeper, the risk of lymph node metastasis is very high. So it will not be a curative resection. So you may be able to remove a lesion, but with no curative resection because they are lymphovascular emboli. So we have some criteria of curable resection. You must have early resection with no lymphovascular emboli, low padding. Those are the criteria of curative resection. Yes, the tear is mostly done for submucosal lesions. We are talking here about mucosal lesions. Okay. So what about the endoscopic classifications when depend on description? Yes?
It's not a 0%, this is the problem. Zero.
Yes, it's never there, of course.
Yeah.
But it's your limit because the risk is very low.
Muscularis mucosa, so
Yes?
SM1 is never 100% safe. It's always 0.0 something or 0.
No, it's not zero, but it is a low risk. So you can go down to the SM1. Below this is a high risk of lymph node metastasis, so it won't be a curative resection. So what about our classifications, endoscopic classifications we will use to describe the lesion? The first is the Paris classification. The Paris classification is a universal classification. You can apply the Paris classification to any lesion in the GI tract. The Paris classification will describe the lesions into protruded lesions, including the sessile, 1S, the pedunculated, 1B, the flat lesions, the 2A, the flat elevated, 2B, completely flat, and 2C, the flat depressed, and the 3 is the excavated. As we go from the left to the right, the risk of deep invasion will increase. So when you see a lesion of a 2C or 3, you can expect there is deep submucosal invasion, and this is an invasive cancer. Those are some photos of some lesions. You can see here this pedunculated lesion. A subpedunculated lesion, it means it has a white base like It is halfway between the sessile and the pedunculated. This is a sessile lesion. This is a slightly flat, slightly elevated lesion. This is a completely flat lesion, and this is a flat depressed lesion. So when we see this lesion, we say there is a possibility of deep invasion. So in the Paris classification, yes?
The previous slide, what's the meaning of 0? 0, 1, 2, C.
This will explain your question, okay? Why 0? Because there are other 5 types. So 0 is the superficial lesions we are talking about for endoscopic resection by their classifications. Because we have other 5 types, they are not superficial, so we call this 0, and the other types are the type 1, which is the polypoidal carcinoma, type 2, the ulcerated carcinoma with sharply demarcated edge, ulcerated infiltrating, non-ulcerated diffusely infiltrating, and the unclassifiable advanced carcinoma. So we are talking in the Paris classification about type 0 because there are other 5 types. Now we will go to specific classifications that apply to parts of the GI tract. We will talk first about the colorectal lesions. The colorectal lesion, the first classification we'll use is the Kudu pit pattern. The pit pattern will describe the shape of the pits on the surface of the mucosa. To do this, you must use chroma-endoscopy, preferably with magnification that will give you every detail. So we have type 1 with rounded pits. You see these blue dots here. This is the pits. Here it is rounded pits, it's normal pits. This is the normal mucosa. We'll go to the type 2, the asteroid pits. You see these blue parts look like asteroids. Like the type 2 will describe hyperplastic polyps. Type 3 will be classified into 3S and 3L. 3S is 3 small, L is large. This is both are tubular, but this is rounded pits and smaller than the normal pit. And here the pit is larger than the normal pit, but they are taking the shape of tubules or rods. Okay? Type 4 is the dendritic type. The dendritic type will look like the brain gyri, gyrus-like pit pattern. Type 3 mostly refers to tubular adenomas. Type 4 mostly refers to villus pattern or villus adenomas. Then we have type 5. Type 5 will be classified into 5I and 5N. Type I is the regular arrangement of thighs of different types. 5N is the non-structural, completely amorphous shape. This mostly will identify deep invasion. So as we are going from up to down, the possibility of deep invasion will be increased. You can see here from the shape of the pits, you can expect the pathology, even of the polyp or the lesion before removing it. Let's see some images. You see this type 1 with the normal pit pattern, the rounded pit pattern. We have this, the type 2 with the asteroid pit pattern. You can see here a mucus cap. This is common for the serrated lesions. Type 3 S with the tubular pattern, but it is smaller than the normal. Type 3L, the tubular, or the rods, it looks like a rods, but larger than the normal. We have type 4. You see this, it looks like a brain, the gyri of the brain. This is specific for villus pattern. Type 5, regular, different types. Type 5N, non-structural, completely amorphous shape. It identifies deep invasion. Okay, let's go to the next classification. We use the genetic classification. The genetic classification will describe the visual pattern and the surface pattern of the lesion and expect the most likely histology accordingly. In type 1, we have invisible visual pattern. The surface pattern is similar to the surrounding mucosa. You can see this. It is nearly similar to the surrounding mucosa. From this shape, we can predict this polyp or lesion is a hyperplastic polyp. Then we have type A, type B, 2B, and 2A and 2B. In type 2A, we have vessels of regular caliber and regular distribution. You can see here the reddish vessels. They have regular caliber and regular distribution, and the surface is regular. It has a regular shape. This will indicate low-grade intramucosal neoplasia, mostly tubular adenoma. Type 2B, we have the vessel pattern with variable caliber and irregular distribution. You can see here the reddish vessels. They are irregular. Compare them to the type 2A. Here they are regular. Here they are irregular. The surface pattern is slightly more irregular compared it to the previous classification. This will indicate high-grade intramucosal neoplasia. So this is low-grade and this is high-grade. So in type 3, you have loose vessel pattern and amorphous areas. You can see this shape. When you see this, this is a deep invasive cancer. So as we go from the left to the right, the depth of the invasion probably will increase. The nice classification is another classification. It is close to the unique classification. We mostly prefer the GNet and use it most of the time. What about the lateral spreading tumors? It is another classification that can be applied. By definition, lateral spreading tumors are any tumors with a horizontal growth more than 10 millimeters. So if you have any lesion with a horizontal growth more than 10 millimeters, you can call it a lateral spreading tumor. Lateral spreading means a growth horizontally more than vertically. So how we can classify the lateral spreading tumor? They are classified into granular type and non-granular type. The granular type is classified into homogeneous and mixed. The granular, it means like it has a bubbly surface like this. When it is completely like this, it's called homogeneous, granular homogeneous. When you have a granular part and a flat part, it's called mixed. About the non-granular, they are classified into the flat and the pseudo-depressed. The flat are completely flat. The pseudo-depressed, they look like a dish. You can see this. As we go from up to down, the risk of the submucosal invasion, deep submucosal invasion will increase. So when you see these lesions probably not invasive, when you see these lesions probably invasive.
The mixed granular flat
Mix of granular and flat. You have a granular part and flat part. Let's see some photos and predict the pathology of the lesion according to the photo. What do you think about this? What is the Kudu beat pattern? Adenoma. What's the Kudu beat pattern? 3. That's right. What's the GNet classification? 2A. That's right. So from the shape of the lesion of the polyp, we can predict the pathology. This is an adenoma. That's right. What about this photo? What's the Kudu beat pattern? 2B. That's right. Irregular vessels with variable caliber. That's right. GNet 2B. What about the Kudu? Kudu 5. What do you think? What do you think? It looks like a gyri or dendritic like? Right? The gyri are 4, not 3. Yes, the blood vessels are 2B. They have variable caliber and regular distribution. That's GNet 2B. And as we said, it may indicate high-grade intramucosal neoplasia or dysplegia. But look at the Kudu beat pattern. It looks like a gyrus or dendritic pattern. So mostly there is a villous component in this polyp. So the pathology here, the tubular adenoma, here the villous adenoma. Okay. Let's see more lesions. What do you think about this? What's the Kudu beat pattern? Can you see the beat pattern? Can you see any shape here, like roads or something? Roads, right? It's mostly Kudu what? Why 5? We can see some details of the surface pattern. 3, that's right. This is a tubular pattern. That's right. So this is a tubular villus adenoma. It has a villus component in addition to the tubular component. What do you think about this? 2C, that's right. If this is a lateral spreading tumor, it's horizontal growth more than 10 millimeter. What type of lateral spreading tumor is this? Non-granular. That's right. Let the best look like a dish. Can you see this? Yes, there is a nodule here. But can you see the depression here? What about the Kudu beat pattern here? Can you see a Kudu beat pattern here? يبقى تايب كام اللي هو مش واضح؟
طيب
يبقى 5. اول ما تلاقيه مش واضح قول 5.
مش معنى ان بي اي
That's right. You are right. This is that deep submucosal invasion. Code 5, the GNet 3, and lateral spreading tumor, the flat debris. This is a deep invasive tumor. This is a malignant lesion. So you can conclude according to the shape and the surface pattern, the vessel pattern, what type of lesion, and predict the pathology, and even you can predict whether it is eligible for endoscopic resection or not. So you can't remove this lesion by endoscopic resection, right? What about this?
I cannot remove. BBC I cannot remove.
No, this is a deep invasive lesion, yes.
What is 1S?
1S, this is right, polyp, that's right. What about the GNet?
Janet, side 2A.
Compare it to the surrounding mucosa. That's right.
Janet 1.
GNet 1, that's right. What about the codobeat pattern?
Should be 1.
1 is the normal mucosa. Look at the pathology you can predict. This is hyperplastic, the asteroid bit. That's right. Hyperplastic will include the serrated lesions, so this is a hyperplastic polyp. Okay, those are about the colorectal classifications. Yes, yes.
For LSD, whenever we mention, for example, non-granular, is it necessary to mention Paris classification as well?
Yes, yes, you mentioned all the classifications. The Paris is a universal classification applied to any lesion. Then, according to the site, you describe the rest of the classifications.
Each legion should give a full
Yes,
method on
yes. Most polyps, more than 1 centimeter, you should describe all these. Yes,
how many I should use and how many of them? All of them.
yes, if we are talking about the colorectal lesions, you should use all of them. You say it is as a side. The side is the Paris 1S. You say the codobeat pattern. When you say C, it is hyperplastic. An example, you say this is codo 2. You compare to the surrounding mucosa. You say it is GNet 1, and so on. You use all the classifications. When you find the lateral spreading tumor, describe accordingly. اتفضل. خاصة في البوليبس اللي حجمها أكتر من سنتي. يعني أي ليجن حجمه أكتر من سنتي الأفضل إنك توصف كل الكلاسيفيكيشنز. لأن هي هتبقى واضحة غالبا قدامك. بشرط إنك تستخدم هاي ديفينيشن سكوب ومعاك كرومو اندوسكوبي طبعا. طيب تعالوا نشوف الجاستريك ليجنز. هل هي هنستخدم نفس الكلاسيفيكيشنز؟ No, it's not the same classifications. Only the Paris will apply here. What about the rest of the classifications? Unfortunately, they don't apply to the gastric lesions. So we have other classifications for gastric lesion. The first is the conventional white light endoscopy classification called the color plus surface classification. The color plus surface will describe the lesion according to the presence of a well-demarcated lesion with irregularity in color, or a well-demarcated lesion with irregularity in surface if the lesion fulfills both 1 and 2, the lesion is cancerous. If it is neither present, so the lesion is non-cancerous. This is a broad classification, just losing the white light endoscopy. Let's see some pics. What do you think about this? Applying the color plus surface classification.
Should return back to previous slide.
That's right, not well demarcated. Memorize that. Irregularity in color, irregularity in surface, and well demarcated. Let's go back to the image. What do you think? Not well demarcated. Is the irregular surface? Maybe some irregularity in color. What about the surface? It is regular surface. So can we describe this as cancerous lesion? No, the classification will not apply for this. What about this? Well demarcated, irregular surface, irregular color. So we can describe this as probably this is a cancerous lesion, early gastric cancer. So it is a broad classification just to classify the lesions. This second one, Yes, but with this is a lesion. It has irregularity in surface and irregularity in color. It has a demarcation.
Mucosa looks expect a lot of atrophic gastritis.
Atrophic gastritis may be on top. You have early gastric cancer. Yes. Okay. Let's go to the next classification, which is called the MESDA-G classification, the magnifying endoscopy simple diagnostic algorithm for gastric cancer. So, as its name applies, you must use magnification to apply this classification. So, if you don't have magnification in chrome endoscopy endoscope, you can't use this classification. So, when you see a suspicious lesion, you look at the demarcation line. So, if you don't have a demarcation line, it's non-cancerous. If you have a demarcation line, look at the visual pattern and the surface pattern. With irregular vascular pattern or surface pattern, if they are present, it is a cancerous lesion. Let's try to apply this on the images. It's called the vessel plus surface classification. You see here the vessel with magnification. It is regular. What about this? You can see the demarcation line. It's clear. And the vessel pattern is irregular, so mostly this is a cancerous lesion. Here, there is a demarcation line, and the vessel pattern is absent. This may indicate a cancerous lesion. What about the surface? You see here, the surface is regular. There is a demarcation line here with irregular surface and even the regular vessel, so it's mostly the cancerous. There is a demarcation line here with absent vessel pattern completely and irregular vessel pattern, so this is mostly cancerous. Let's apply this on the following images. You see this suspicious area during an endoscopy, you use magnification and you see this. What do you think? That's right. That's right. So this is not a cancerous lesion.
You just say that it is a benign lesion? Or
Yes, just inflammation maybe. There is no
I record
Yes.
it is a benign lesion?
Yes, just maybe just inflammatory area, just not more. What about this? You see this area during your endoscopy. You use chroma endoscopy. This is a magnification image. This is the chroma endoscopy and this is a magnification image. When you apply chroma endoscopy, you see a well demarcated area. You apply magnification and you see this. You see the demarcation line, compare it with the surrounding mucosa and look at its surface. So it turns to be an early gastric cancer. You can see when you suspect a lesion, you must use your chroma endoscopy in your magnification to classify the lesion and predict whether it's cancerous or not. So those about the gastric lesions. As we said, the Paris classification will apply anywhere. So it applies also for severe lesions with other specific classifications. So the main types of cancer we have in the esophagus are the adenocarcinoma and the squamous cell carcinoma, right? For the adenocarcinoma, it arises mostly on top of parrot. The most famous classification for the parrot is the Bing classification, the Barrett International NBI group. So the Bing classification for the parrot will classify the lesions into dysplastic or non-dysplastic according to the surface pattern and the vessel pattern. Whether the mucosal pattern is regular or irregular, the vessel pattern is irregular or regular. Just a simple classification. Both are images of non-dysplastic Barrett's esophagus. So you see a Barrett's esophagus, you apply magnification and use chroma endoscopy, and you try to see whether there is irregularity in the vessel pattern or the surface pattern. In both images, there are no irregularity in the vessel pattern or the surface pattern. Is called a non-dysplastic Barrett's esophagus. There is no dysplasia here. What about those images? Try to see these images and see the irregularity in the surface and the vessel. Can you see them? So this is called a dysplastic Barrett's esophagus. So it classifies the Barrett into dysplastic and non-dysplastic, and you can predict the presence of dysplasia using your endoscopy.
Just one question.
Yes.
Actually, in Barrett's esophagus, one of the most important problems is for us it is first to diagnose. Does it look like Barrett or just irregular line?
That's right. If it's it has first to be more than 1 centimeter to suspect Barrett, not just irregularity. So if it is more than 1 centimeter, apply this magnification, take biopsies to confirm your diagnosis. Yes? Yes.
not consider about this or it should be more than 1 centimeter.
More than 1 centimeter, that's right, that's right. And then you can apply it to the Bragg classification. Yes.
Sometimes the G junction mucosa is just congested, looks like adenomatous tissue.
Yes.
Most of the time we are seeing this in our daily practice. I don't know what is your explanation, how to interpret it or how to report it.
Yes. Sometimes you have something called the Z-line gastritis or the cardiac gastritis.
Yeah.
It is not precancerous and it's not important to biopsy that.
It's on the gastric side, but
Yes.
G junction.
Yes, at the G junction, yes.
That is a
Not precancer, not precancerous, no. You just suspect Barrett if it is more than 1 centimeter above the Z-line.
Barrett's can be diagnosed if less than 1 centimeter above Z-line, but it has no surveillance. If I found Barrett's, Barrett's means columnar epithelium above Z-line.
Yes.
And it's very easy for any endoscopist to know this Barrett's because it has different colors than the
That's
normal
right.
color. But the surveillance is not necessary for Barrett's less than 1 centimeter.
Yes.
But can be
And the
done-
biopsy is not necessary. You don't have to take a biopsy.
Yes.
So you don't give it any importance. Okay, let's go to the classification of the squamous cell carcinoma, the second most common type. This is the Barrett's classification of different types of squamous cell carcinoma. Can you see this? What Barrett is this?
Three.
3. That's right. It's an excavated lesion. 3. Mostly, this is a deep submucosal invasion.
This is the same classification.
What about this? Yes.
The same classification.
At the Barrett's classification. Yes, the Barrett's applies anywhere. Yes.
2A plus 2C.
2C.
2B plus 2C.
You said right in the first time.
2A plus
2A blood right. It is a flat elevated with a central depression, so we can combine two Barrett's classifications in one lesion. You may have, an example, a flat lesion with a nodule. You can say 2A plus 1S. The flat elevated with central depression to A plus C. So we can combine two classifications. So we have these classifications called the Japanese Endoscopic Society Magnifying Endoscopic Classification for Squamous Cell Carcinoma. It will classify the squamous cell carcinoma according to the type of vessels into A and B. B is classified into B1, B2, and B3. The A is the normal intrapapillary capillary loop. You must use magnification also for this classification. The B2 are the abnormal microvessels with severe irregularity. Type B1 with a loop-like formation, it looks like a loop. Type B without a loop-like formation. Type 3 is dilated 3 times more than the previous types. As we go down, we can suspect the invasion is more. Here is no invasion. T1E, MM, T1B, T1B, SM2. As we go down, the invasion may be deeper. Let's see these images. This is the type 1 we described. Normal, the intrapapillary capillary loop. It is non-neoplastic. This is the image of type 1. When you magnify, you see this image. About the type B1, loop-like formation, mostly the lamina propria or the epithelium. You can see here more loops folded upon itself. This is the type B1. About the type B2, regular vessels with no loop-like formation. You see, those are the dilated irregular vessels, but with no loops like type B1. Type B3 with high dilated, more than 3 times. You see the dilatation here and compare it to the previous one. This indicates a more deeper invasion. Yes, of course.
You mentioned you should use magnifying endoscopy.
Yes.
For example, in Fuji we have Z. We should use Z, zoom.
No, not the optical zoom. It is the digital zoom. You have to magnify the image while maintaining its details. It's not present in the older scopes. So it has not the optical zoom, it is called the digital zoom or digital magnification. It magnifies the image while keeping the details.
So this feature is present in which scope?
Yes, you also have a feature in your scope for magnification. Yes.
It is zoom. It is Z in Fuji. I think it is same. Exactly. Fuji has zoom scope. Zoom. So by zoom we can see this.
Not the optical zoom. Older scopes have something called the optical zoom.
Yes. It has a feature by
Yes.
Z. When we have gastroscope with Z or colonoscope with Z.
Yes.
So we can use for
Yes, yes,
very low.
yes.
And then how we should apply? Just applying the zoom, or we have to put water at the same time
No, no, that's just apply the zoom use chromoendoscopy.
without
Yes.
If you want to a better quality of image, like here, you have those lightning flashing. You have to use a if you want to eliminate this, you actually have a black hood attached to the scope,
Yes.
and you getting closer to the mucosa in esophagus, and you use the minimal saline
Yeah.
to have a water image happening to avoid all these flashing back.
Okay, that's right. That's right.
Then you can produce
better magnification.
good magnifying figures.
Like,
So I'm a very strict reviewer on those magnifying papers. If they are not producing nice magnifying picture, I said you are not a good magnifying person. So
Yes.
I will refuse those papers, like if you are not producing good magnifying figures.
So you mean you should press on the water jet slowly?
Very,
low-
you
low-
put it in the lowest pressure.
Yeah,
But if you want to do as I say, it's also doable.
yeah,
It's slowly flushing into the cap.
yeah.
So that because in the cap, there's only minimum water. Because when you are doing the esophagus magnifying, the anesthesia will be worried that you get intensive water into the esophagus.
That's right. That's right.
a previous classification
Okay.
definition here, according to the blood vessels,
Yes. It's called the intrapapillary capillary loops, IBCL.
is the
Yes.
option of zooming, digital zooming.
Yes.
Is it like a button?
Yes, yes, it's a button that you press.
And this is only for squamous cell cancer?
This classification, yes, is for squamous cell carcinoma. We can see here some images. This is a type B1 vessels with the loop-like formations. You can see the vessels here are folded upon themselves. This is the type B2 with the non-loop-like dilated and the regular with non-loop-like, and type 3 with dilated more than 3 times the previous types. Then we have auxiliary criteria, added criteria to the previous classification called the avascular area. When you have a vascular area in the middle of your lesion, according to each size, you can even predict more depth of invasion according it is whether it is small, middle, or large. Those are some pictures of small, medium size, and large vascular areas. Okay, the duodenal lesions are not used commonly in clinical practice, so don't concentrate on those ones. This was a trial for putting a unified classification. There are so many classifications, they try to group them into one classification called the unified magnifying endoscopic classification using the unified criteria. Essentially, they use the same previous classification but just change the names. So it doesn't add a lot of benefit to the previous classifications. Okay, we are done with our lectures. Do you have any questions?
Yes. What about tissue cipher in diagnosis of Barrett's and management of Barrett's esophagus? Tissue cipher.
Tissue cipher.
Yes.
We don't use it in clinical practice. You have any experience with them?
No, this is a new AI amendment tool which can diagnose the prognosis of this Barrett's, whatever in histopathology it's plastic, multidysplasia or
Yes, yes.
and it shifts the paradigm in United States, so they use it now as for management of Barrett's esophagus.
Yes,
And
yes.
it's only AI, so we can bring it here in Egypt. And my thinking to work on this category of Barrett's of 1 centimeter.
Yes,
It
yes.
is done 1 centimeter.
Yes.
To see, is it carry any hazards for
Yes.
malignant?
Yes, that's a great idea. Yes.
Paradigm, and I think it will shift the paradigm worldwide.
Yes,
Not in
it's
United
not yet
States.
available here. We don't have experience with
It's
this.
only
Yes,
AI.
yes,
You can contact Fuji to bring it.
yes.
It's very easy.
My question, what is the current application of dye-based chromoendoscopy? Because
Yes. You can,
practice
yes, you can use the dye-based chroma endoscopy as a substitute. They can be used in esophageal lesions like the Lugol's iodine. We have seen some pictures yesterday of the Lugol's iodine spraying. You may use dye spraying in screening for inflammatory bowel disease as a colitis. It's available to use the dye paste. It's okay.
Another question for Barrett's esophagus. What's the recommended time for observation of esophageal lesions like Barrett's esophagus? Recommended time, average recommended time.
For the screening,
No, no,
Oh.
no. Average recommended time for visualization, good visualization, adequate visualization of the esophagus to search for Barrett's.
the time for the examination in the endoscope itself,
Yes.
yes, I think it is at least 5 minutes during the gastroscope. Do you have any more questions? Okay, thank you.
Good morning, everybody. Bismillah ar-Rahman ar-Rahim. I have a short lecture about prevention and management of complications in advanced therapeutic endoscopy. All of us know before starting to do advanced endoscopy, ESD and POEM, you should be oriented what are the complications you may face and how to prevent, and even if it occurred, how to manage. So this is a very important topic. All of us know that ESD developed for resection of early cancers for en-bloc resection. So as after resection of the lesion, the histopathology confirms this lesion is curative resection and no residual tumor for chemoradiotherapy. So high level of experience is required for managing and prevention of ESD complications. What are the complications of advanced therapeutic endoscopy? What are the complications of ESD and POEM? You know. Yes. Okay. Yes. Very good. What is the most dangerous from these complications? What is the most fearable complication? Actually, we get fear from bleeding more than perforation, because usually perforation, most of them we can close perforation, but sometimes the bleeding is very horrible and maybe more hazardous than perforation. We will see some cases. First of all, perforation. Perforation can occur intra-procedure during the procedure, or it can occur delayed perforation after you close and the patient is discharged home. Delayed perforation may develop. How to prevent perforation? There are some tips and tricks during resection. Usually use a suitable knife. So in ESCD, use a knife with short tip, 1.5 or 2 millimeter, not long knife, 4 millimeter like in POEM. Be ready to use IT knife. IT knife means insulated tip knife. In some areas of resection, you are going to do resection blindly. So be ready to have IT knife with insulated tip to resect by the shaft, not by the tip. Avoid dissection in a perpendicular plane to the muscle. So this is the importance of doing pocket ESCD. Pocket ESCD means opening the mucosal incision, then entering the scope inside the tunnel, so the scope will be parallel to the muscle, not perpendicular to the muscle. Ensure proper cushion. Always inject to expand the submucosa, so you can dissect in the submucosa, not in the muscle layer. So ensure proper cushion. Sometimes we use colloid rather than crystalloid. You can add methylene blue over a colloid, not normal saline, to ensure proper cushion during dissection. Ensure clean field. Sometimes when the field is not clean and with a lot of carbonization, you can't see the proper plane of dissection. The proper plane of dissection, which is the submucosa, should be always clean during dissection. So these some tips how to avoid perforation. But despite all these preventive methods, sometimes you encounter this perforation during resection. How to deal with this situation?
After you finish, you will make equilibrium.
The first life saving to do needle decompression of the air escaped from the lumen into the peritoneal cavity. Usually we use CO2, but if a lot of air or a lot of CO2 escaped from the lumen into the peritoneal cavity, the peak airway pressure increases and the saturation of the patient starts to decrease. So the anesthesia doctor asks you to do needle decompression of the abdomen to evacuate the abdomen from the escaped air. Then you can close the defect. How to do needle decompression? This is a video for illustration, how to do needle decompression. We use a syringe with 20 cc normal saline and introduce the syringe in the right loin or right iliac fossa and remove. You can keep the needle in the right iliac fossa to decompress the abdomen. After you finish and close the defect, you can remove the needle again. So this is the first important step after doing perforation. Sometimes the needle accidentally inserted inside the bowel, not in the peritoneal cavity. How to differentiate? If the needle punctures the bowel, it will bring froth, which is in the left side. But if it is in the peritoneal cavity, the bubbles are clear, which is the syringe on the right. So if you accidentally puncture the bowel, it will bring froth on the left side. So simply remove the needle a little bit away and it will be inserted inside the peritoneal cavity. So this how to differentiate between if the needle inside the bowel or in the peritoneal cavity.
And after you puncture the bowel, there is no hazards for this patient?
No, this is a very simple puncture. Just you should retrieve the needle a little bit away. So after relief of the pneumoperitoneum, how to close the defect? If the defect is small, simply you can close it by several endo clips. Like this case, we used 3 or 4 clips to close the defect after completing the resection of the lesion. But sometimes the lesion, the defect is very large. The largest clip, which is 17 millimeter, can't close the defect. So we use a technique named a purse string technique. Purse string technique, we use an endo loop and several hemoclips. The role of the clips is not to close the defect. The role of the clips is to fix the endo loop over the defect. Then we close the endo loop, so the defect will close. This is a video for illustration. This is a large defect with peritoneal fat. So we use the endo loop, we fix the endo loop over the defect by 4 clips. So the role of the clips here is not to close the defect. It only fixes the endo loop over the boundaries of the defect. Then we close the endo loop. After closure of the endo loop, the defect is closed and the stomach gets insufflated again.
Look, now there is a clip 22 millimeter. Can it work?
Yes, sometimes we use a clip known as mantis clip. You can drag the edge of the defect from one side to the other side to close. But if it's not available, we can use this purse string technique.
Here I saw the envelope and I released the envelope.
Yes, yes,
Completely released.
yes, and you can catch it again by the hook. Yes. If the patient is completely prepared and no stool and no soiling, no contamination, you can close it, yes, also.
Is there a pneumomediastinum? Talk about the
Neoperitoneum, neomediastinum,
Do you get any emphysema, for instance, when you
sometimes
have a
pneumothorax occurs. Pneumothorax, you can insert a needle in the second intercostal space to relieve. But this is a temporary maneuver. Usually the patient needs intercostal tube after the procedure.
But how do you recognize it? Because pneumorhythm is recognizable. How do you recognize it?
Usually the saturation of the patient decreases, starts to decrease. And sometimes we work in the OR and there is a fluoroscopy. You can do a fluoroscopy to check if there is pneumothorax or not. Not frequent, not frequent, not frequent. Not frequent, but occurs. So what about bleeding? Bleeding sometimes occurs intra-procedure or delayed bleeding after closure up to 3 weeks post-procedure. You can encounter delayed bleeding. There are several risk factors related to the patient. If the patient takes anticoagulants or antiplatelets, what about the comorbidities of the patient? Sometimes several risk factors contribute to the delayed bleeding. How to prevent bleeding? You should be fully equipped. You should have auxiliary water channel, no role for all the scopes in advanced therapeutic endoscopy. The scope should have auxiliary water channel and irrigation pump. So once bleeding occurs, you can wash by the irrigation pump and capture the blood vessel by the coagrasper or hot biopsy forceps. So you can't use the same channel for irrigation and for capturing the blood vessel. You should have a scope with auxiliary water channel, because one channel for irrigation and the other channel for the hot biopsy forceps or the coagrasper. You should be ready with a smart electrosurgical unit, and you should be aware by the different modes of coagulation. What is the difference between soft coagulation, forced coagulation, swift coagulation, and this is a separate session today. You can do prophylactic coagulation. During dissection, you can encounter a blood vessel like this. Simply, you can prophylactically coagulate it by the shaft of the knife by soft coagulation. So you can do prophylactic coagulation by the knife. But while you are doing dissection, bleeding sometimes occurs. If it is a simple oozing, you can manage the bleeding by the same knife. But if it is a spurting blood vessel, you should shift to hot biopsy forceps or coagrasper. Simple. Yes, yes, from forced coagulation to soft coagulation. Here there is bleeding during dissection. We do irrigation to localize the source of bleeding. Then by the shaft of the knife, we can coagulate the blood vessel. So this is the importance of having an auxiliary water channel to localize the source of bleeding, then coagulate the blood vessel by the knife. And after coagulation, we should irrigate again and ensure that there is no residual oozing.
So you are saying double channel endoscope is a must if you want to...
Not double channel, not double channel. It is a single channel scope with auxiliary water channel. The double channel scope means you have two working channel. No, here not two working channel. One working channel and the other channel is for irrigation only, attached to a pump. Yes. Sometimes the bleeding is very extensive, like this case, spurting a blood vessel. It is very important to do ESCT in the anti-gravity side, because sometimes if you do resection in the gravity side, the blood accumulates over the lesion and you can't localize the source of bleeding. So it is preferred to put the lesion anti-gravity, especially in the colorectal lesion, because if bleeding occurs like this, the blood should accumulate on the opposite side.
Like the idea when we inject further before we put the patient right lateral decurtus, because if we put it in the left lateral decurtus like normal endoscopy, you cannot see anything, you cannot visualize
Yes.
or determine the side.
Yes, yes,
This
exactly.
right lateral decurtus is a mentioned Dr. Mazi.
Yes, yes. Very common in colorectal ESCD. We do ESCD while the patient is looking for us, looking for the endoscopist on the right lateral position. Most of cases of delayed bleeding could be managed conservatively, but if bleeding is ongoing, you should repeat endoscopy. So,
Before the picture, regarding the bleeding, you mentioned for coagulation, we change the mode of the LV
yes.
machine. So is there any mode that we can use for PST dissection and for coagulation at the same time, just by changing the pattern
Yes,
from
yes.
the valve to cut?
There is some coagulation mode can do dissection by coagulation, like forced coagulation and precise sect and swift coagulation, and also spray coagulation. But soft coagulation is a non-cutting mode. Soft coagulation, you can do coagulation only, but it will not cut the submucosa. But you can do submucosal dissection using spray coagulation or forced coagulation or precise sect coagulation.
And to cut by same mode, not changing.
These coagulation, I'm talking about the coagulation mode.
No, just select one mode from beginning to the end of your
Ah.
procedure and do everything by that mode.
Yes, right, that's right. You can use precise sect mode or forced coagulation mode from the start. You can do all dissection by forced coagulation. You understand? I don't understand the question.
No, I see some experts, what they are doing, they don't change the mode.
Yes.
Same mode they use for, if they have bleeding, they just press on the blue part.
Pedal, yes.
Pedal.
Yes.
When they want to go and they go to the yellow.
Yes.
One by the same mode. This was my question.
Okay, this sometimes occurs, but actually, usually, we if there is a minor oozing, we use soft coagulation so as not to penetrate the muscle, because forced coagulation is powerful mode. You can do muscle injury, and it may produce delayed perforation after this.
When you select coagulator for bleeding, and when you use the knife fixer.
Usually minor oozing, like the last video, you can stop the bleeding by the same knife. But if there is a spurting blood vessel, you can't control the bleeding by the knife. You should switch to hot biopsy forceps or coagrasper.
So it doesn't depend on the vessel size, for example. It's not bleeding, but I see a large vessel.
If there is a large blood vessel larger than the caliber of the knife, you should switch to hot biopsy forceps or coagrasper. But if the caliber of the blood vessel is as caliber of the knife or smaller than the caliber of the knife, you can use the same knife to coagulate the blood vessel. So what about the stricture? Stricture usually occurs within 2 to 4 weeks after circumferential or near circumferential lesions. This is one of our case, near circumferential Barrett's mucosa with intramucosal cancer. We did almost circumferential esophageal ESD, a case similar to what Dr. Hiwa presented yesterday. After resection, we have a very large row area, almost circumferential. So here the percentage of developing stricture is almost more than 90%. This is a circumferential or near circumferential esophageal ESD. Another colorectal case, a rectosigmoid lesion, almost circumferential. After resection, we have a very large row area of circumferential rectal ESD. So these cases, you should have some preventive maneuvers to prevent stricture. How to prevent stricture in these cases? Yes. We can inject intralesional steroids, but sometimes we are fear of delayed healing, or the healing is not very well after injecting steroids. So we prefer to give the patient oral steroids, 30 milligram oral steroids. Sometimes we use steroid enema or